Right, well, welcome back. New day, new shirt. Uh, all right, welcome. New day, new plaid shirt. So let's get back into it. Just brief disclaimer again, if you're coming in the middle, this is an antibiotic talk. That being said, it is edutainment. If you just look in the bottom right corner, I'm sure you'll see cats chasing laser pointer videos. So just recall that all information you need to verify. Things change over time, and depending on when you're watching this, some of this might not even be true anymore. Um, always, therefore, check your local antibiogram because that'll give you the best information in terms of what antibiotics to use. And then, of course, don't underuse antibiotics, but don't overuse antibiotics. So there you have it. Easy, simple. What could go wrong? All right. So I think where we left off last time was rifampin, right? And we said rifampin was great, did everything. Which then leads us to the next. Let me make sure this is the copy. Yes, perfect. Which then leads us to uh, moving down our little chain here. So we had trimethoprim sulfa dealing with um, blocking DNA synthesis. We had the fluoroquinolones blocking the topoisomerases. We had rifampin blocking transcription, which then leads us to RNA. And as of now, we do not have anything that just chews up the RNA of bacteria. That being said, that is sort of where RNAi comes into play. And hopefully someday we'll manage to use that attack vector. But for now, there's not a well-established commercially available RNAi against bacteria anyway. All right, which leads us to the next step, which is translation. So that's where we're at now, and let's pick a different pen color, shall we? Let's try this nice blue here. All right. So, what does translation recall? It is the ribosomes. So ribosomes mediate translation. All right. So, what do the ribosomes look like? Well, there's a little piece, the 30S ribosome, and we have a bigger piece, the 50S ribosome. And they come together, and then the RNA strand is kind of fed through the gap like this. And in comes the RNA strand, and out comes your protein strand. Let's make proteins red. They do everything. So here comes your protein. And then it's folded up and becomes the molecular machine that powers everything. All right. Let's go back to blue. So I don't think it's honestly that critical um, that you just learn which ones, which antibiotics fit into which piece of the ribosome. But that being said, I think it is helpful to just categorize them in some place to start with, and then we can go from there. But I don't think committing them to memory is necessarily that helpful. All right, so let us divide this up. So in terms of 30S inhibitors, we have a few. We have tetracyclines, and we have the aminoglycosides. And actually, there's a derivative of tetracyclines, fierce like a tiger, tigacycline, which is a glycylcycline. So we have the glycylcyclines too. So a lot of Y's. Glycylcycline. There we go. And then over here, one second. Edutainment. Edutainment. Okay. Sorry, I keep looking over here because that's where my broadcast is, and I'm like talking to myself. Try looking here more. So, over here on the 50S ribosome, we have uh, clindamycin, which is a lincomycin. So we have clindamycin. We don't really have lincomycin in the US, so it's just clinda. We have clinda. What else do we have? We have. Uh, and then we have the macrolide antibiotics. The macrolides, which are things like erythromycin and clarithromycin, and we do have a few other interesting groups, although we don't use them terribly often in clinical medicine, but it does happen from time to time. We have the streptogrammins, streptogrammins. It's also known by the brand name Sinercid, which is a combination antibiotic called um, quinapristine, dalfopristine. And then a very old school antibiotic, which we almost never use anymore, at least in the US, but of course it's still a widely used drug in the world, and that is accepted in laboratory settings in Western nations, but that is chloramphenicol. All right, so this kind of gives us a little stage to work off of, and we will kind of go through them. And oh, I'm sorry, there is one other class of interesting antibiotics, and that doesn't quite fit into our little. Okay, fine, thank you. And that does not quite fit into our classic categories, and that is the oxazolidinones. 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 Oxazolidinone. Uh, anyway, linazolid, linazolid, and its cousin tadazolid. And interestingly, these guys will bind the 50S ribosome, but they prevent the 30S from coming in, so it essentially prevents assembly of the ribosome complex. All right. So let's, without further ado, let's start on these things because there's a decent amount to cover. All right. Let's just actually do them up here one by one. So, we use a lighter blue. Let's use a lighter blue. So, let's start with the aminoglycosides. It's a very good place to start. Glycosides. glycosides. And in here we have gentamicin and dobromycin. Why does one have a C and the other have, I'm sorry, why does one have an I and the other has a Y? I don't know, but just does. And we have amikacin. Why does this not even have a mycin? Again, it's just the way it works. Hopefully people will get a little better about naming things. Um, it should be glycoside, right? Or dobroglycoside or amiglycoside. Anyway, so here we are. There are, in fact, some other ones that are still used once in a while. Like, for instance, the average consumer who gets a cut will use this aminoglycoside. No, so it's neomycin. But it's too toxic to actually put in a vein, so you just rub it on your skin. We got, uh, back in the day, kanamycin, although it's almost never used anymore because it's so ototoxic. We have, uh, like if you ever get an intestinal amoeba or certain other parasites, you might use paramomycin. Again, it's too toxic to give intravenously, but you can eat it. It doesn't get absorbed, so you can use it in the gut, or you can put it topically. So people with cutaneous leishmaniasis, it's one treatment for that. And there's good old classic streptomycin, which is still used for several infections, and we'll talk about a couple interesting ones that the aminoglycosides treat beyond this group. But anyways, the most clinically relevant ones you're going to be using are Gent, Tobra, and Ami. So let's kind of talk about them. In terms of going down our list and gram positives, you'd think like, okay, these are most people will think of these being gram negatives, but actually, if you look, it very frequently will treat MSSA. Odd, but it does not have very good susceptibility of MRSA. And why is that? Remember, it's an aminoglycoside, so it does not, I'm talking to myself over there, so it does not have anything to do with the methicillin, penicillin binding protein situation. It is just working on the 30th ribosome, although curiously, I'll start using curiously more. Curiously, it does actually have an effect on the bacterial membrane as well. So there is likely some effect on the bacterial membrane that causes it to be partly bactericidal and not just bacteriostatic. All right, but I digress. So it does actually have activity on MSSA and MRSA. Now, is it a great antibiotic for MSSA? No. And just like we were talking about with the fluoroquinolones, MSSA will just have more susceptibility compared to MRSA. And that is, again, because of the resistance cassettes that MRSA has. When you get one, you get a bunch. It has much less activity on the streps, and we'll talk about why in a little bit, but much less activity on especially the viridins group streps and pneumococci, so generally would not use aminoglycosides in either of these situations clinically. Enterococci, similarly, generally will be resistant, although historically, if you use it in combination with a penicillin, you can actually get some degree of synergy, like having some effect on the cell wall, and then allowing the aminoglycoside in seem to cause increased killing, although it's somewhat falling out of favor in terms of using synergistically for endocarditis. All right. Where the aminoglycosides do in fact shine are the gram negatives. So definitely work on the gram negatives. Um, E. coli, Kleb, Proteus, basically all of these will generally be susceptible, although unfortunately in this, modern era of antimicrobial resistance, when you have highly drug-resistant E. colis and Klebsiellas and Enterobacters, in many cases, just like this, just like we were talking about with staph and the fluoroquinolones, when you get resistance to one, you tend to get resistance to a lot. Um, Notably, uh, Gent and Tobra, when a E. coli, for instance, in the ESBL is resistant to Gent and Tobra, it will frequently, but not always, still be susceptible to amikacin. So it is sometimes useful to check both of the susceptibilities, specifically to amikacin, because you might get away with it. All of them have pseudomonal activity, but tobramycin tends to have a little bit more activity, meaning it usually has Pseudomonas usually have a slightly lower MIC to tobramycin compared to gent and amikacin, whereas curiously, Serratia, who I haven't even talked about Serratia yet. What am I doing? So let's make Serratia red just for funsies because it tends to make things bright red. It is, I believe, let me verify this, but I believe it's actually Serratia is technically an Enterobacteriaceae, or Enterobacteriales, but we would still consider it an environmental gram-negative, and my internet's very slow, so we'll just wait on that confirmation while we move on. All right. But Serratia is the exact opposite of Pseudomonas. So this is just trivia. I don't think it's necessarily that helpful for the average person to know, but we'll just mention it anyway. But Serratia tends to be more susceptible to Gent compared to Dobra for whatever reason. They do, in fact, work on Neisseria species. In fact, if you have a pen anaphylaxis, then for pelvic inflammatory disease, gentamicin is considered an alternative therapy, at least for now. Now, for how much longer? Gonorrhea is, in fact, becoming more and more multi-drug resistant, so, good luck in the future, everyone. And will have activity on Moraxella. I don't think they have great activity on pertussis. Do they work on atypicals? The answer is no. They do not have. Where's my pen? They do not have great atypical coverage. And do they work on anaerobes? This is where I remember way back in med school, our lecturer said a good mnemonic is a me no O2 glycosides, meaning they do not work. I don't know why that's such a hard mnemonic to think about, but they do not work on anaerobes, and that is because of the unique metabolism of anaerobes. So the way I mentioned that there is an effect on the membrane. So these are kind of the aminoglycosides are kind of these charged molecules. They need that proton motive force to pull the aminoglycoside across the membrane and get into the cell. And because anaerobes do not have the electron transport chain that is how all the facultative aerobes or the facultative anaerobes aerobically respirate, they do not generate that same proton motive force that you need to pull them across the membrane. So in general, the aminoglycosides do not work on anaerobes. And that is curiously why they don't work very well on strep species, particularly the viridans group streps, because viridans group streps, oddly, do tend to prefer anaerobic growth. They will and are perfectly capable of living in an oxygenated environment. That's why, they're prominently found in the mouth where there's plenty of oxygen coming in and out. But they tend to favor when there's sugar around fully anaerobic respiration or fully anaerobic metabolism. So yeah, not going to work on that. And then mycobacteria. Do the aminoglycosides work on mycobacteria? You think like Gent and Dobra? No, absolutely not. But amikacin is actually a star here. We frequently, especially when facing drug-resistant TB, multi-drug resistant or extensively drug-resistant TB, or certain difficult-to-treat NTMs, particularly Mycobacterium abscessus, those would be indications for using amikacin. Unfortunately, they're very long courses, and you do end up with toxicities. So let's talk about toxicities first, and then we'll talk about clinical utility and why in many cases, the aminoglycosides have fallen out of favor, but when it's still reasonable to use them. All right. So when do we when do we not use these? What are the problems with these? And I think most people will recall that nephrotoxicity is a big one. Even the modern generation, though not nearly as bad as paramomycin or neomycin or kanamycin, which a few doses would completely destroy your kidneys. They do have nephrotoxicity over time, um, and it's really unavoidable. But usually with short courses, the nephrotoxicity, especially with the modern generation, is low. Similarly, the other big one is ototoxicity. Ototote. Sorry. Ototote. Otototo. Ototoxicity. One word. All right. And finally, so, especially these guys were certainly more notorious for it, but, you know, generally any course of gentamicin, Tobruk, Ami, once you start passing that 5 to 7 day threshold, ototoxicity definitely starts to become a concern. So you especially have to worry about patients, for instance, in pediatrics, they can't communicate that they're starting to feel issues or ringing or that kind of thing. And unfortunately, the ototoxicity is generally irreversible. It kills the neurons, and that's the end of your hearing. And certainly with difficult to treat TB and non-tuberculous mycobacterial infections, you have to sometimes choose using amikacin, and they need long courses, and it's sort of a risk between either dying of tuberculosis or one of these NTM infections or your hearing. And unfortunately, it's unfortunately a Sophie's choice sometimes. Um, Finally, we have something that I don't think gets talked about too much, but it is a very important one to remember, and that is neurotoxicity. And the type of neurotoxicity is different. So remember in the fluoroquinolones, we had talked about things like headaches and dizziness and that kind of thing. But with the aminoglycosides, the site of neurotoxicity tends to be more at the neuromuscular junction. And that is why we worry about using them in situations, particularly like myasthenia gravis, um, and another one that there's certainly certain things like spinal muscular atrophies, and then one of which that you might be shouting about is botulism. So remember, botulism's toxin works at the neuromuscular junction, cleaves um, the snare proteins, and so prevents vesicle release and can damage the end of the neuron as well. And when you give somebody, so there's always a little bit of mythology about antibiotics in botulism, and some of it might be real, some of it might be overblown, but there was always this concern, especially with infant botulism, giving antibiotics made the infant worse, and that is true. If you give antibiotics, specific antibiotics, the infant very likely will get worse. And what is that antibiotic? Well, remember, infants very frequently, especially classically, were given Ambigent for just about all their infections. And it's still fairly common use combination, although we'll talk about why there's pluses and minuses to that idea. So, um, so the patients would acutely get worse, and so there was this thought, okay, well the antibiotics are popping these bacteria, and the bacteria are then spilling out all this botulism toxin into the infant, and that's causing them to have this collapse. But more likely than not, it was the gent itself that was causing the issue, because of this issue where gent worsens illnesses at the neuromuscular junction, would certainly cause more acute respiratory collapse of the diaphragm, and worse floppiness, worse constipation, all that stuff. Well, not constipation, that's not neuromuscular junction, but at least worse in terms of motor tone and respiratory tone. So, you know, why doesn't the popping make sense? Well, bacteria don't tend to store up giant vesicles of toxin and then just pop and spill it all out. They tend to sort of produce on demand. And if botulism is making a toxin, it's just making a toxin. It's not likely that by killing it, you're going to just suddenly release a huge ton more. Endotoxin's a little bit of a different story, because endotoxin is actually just lipopolysaccharide in the outer membrane. And of course, lipopolysaccharide is a structural molecule in the outer membrane. So if you destroy the membrane, you will in fact release a lot of endotoxin into the bloodstream. And so that's a little bit of a different story. But nevertheless, there is still that concern. We do in fact treat. So if you have, for instance, a patient who is an IV drug user and they have a necrotic abscess in their antecubital fossa or wherever, they are at risk of wound tetanus and wound botulism. And you do treat them with antibiotics, and they don't necessarily acutely get worse, because you're popping all of those bacteria. So I think that's more mythology than it is real, and it was most likely the gentamicin. But you do have to worry about using these in patients with, for instance, myasthenia gravis, spinal muscular atrophy disorders, or other issues at the neuromuscular junction. All right. So those are the big three toxicities that you have to remember. So when can we clinically use these, and why is it maybe not, why do we need to kind of use them still, but use them judiciously? So there's a couple reasons why people initially thought the aminoglycosides were very, very useful. Why are they useful? Like, when do we use them? So there was always a thought about using combination therapy, right? And the idea being, especially in vitro, if you give combinations of antibiotics, like penicillin in a completely different class, can you reduce the risk of developing resistance? Because now you're hitting a bacteria from two different angles. Shouldn't it be harder to develop resistance to? Similarly, wouldn't it be more efficacious? You're killing them better, right? You're hitting them from two different angles. It should be better. And if you look in vitro, you do in fact see some distinction, some improved killing, and some decrease in the development of resistance. But when people did large clinical studies with aminoglycosides in combination, they never found that it really changed the overall clinical outcome. Patients still developed resistance at similar rates, so it didn't make a great justification for using combination antibiotics in many cases. The other reality is that, and why is that? It's tough to say, but remember, you do have this large reservoir of bacteria, especially in my gut these days, given the size of it. You do have these and they're being exposed to low doses. So does the combination actually kill or prevent the development of resistance in there, so that your subsequent infection is less resistant? Probably not. It's probably just being exposed to two different antibiotics, and then the next time you get an infection, it's now got resistance, just like if you didn't use combination. Um, the other thing that's important to note is that people were wondering, well, what's the best antibiotic to use? And so they did head-to-head studies of beta lactams versus aminoglycosides in terms of, ooh, zoom in, but then doesn't zoom out. So they did head-to-head studies, and okay, that's annoying. They did head-to-head studies, and they found that generally beta lactams just patients did better, lower mortality, better efficacy, better outcomes. So between the toxicity and the decreased clinical efficacy, aminoglycosides really sort of fell out of favor in terms of general use. That being said, are there some clinical uses for aminoglycosides? And the answer is yes, there are. I still use them to this day. And where do we use them? There's a few places. Let's make some room. And the 30th ribosome is a U. Maybe I'll use this one. Let's see. Base. That's working a little better without necessarily damaging my. Oh. So where do we use these? So in severe sepsis, and in, like, for instance, somebody coming in with, let's say they have a malignancy and they're neutropenic and they are presenting in severe sepsis. What do they have? And the classic story is they have gram-negative sepsis. And why gram-negative specifically? Well, remember that the outer membrane has that lipopolysaccharide protein, the LPS. And that lipopolysaccharide protein is very, very inflammatory. We have, in fact, in our bodies, a large amount of things called lipopolysaccharide binding proteins. And their job is to pick up on the fact that there's lipopolysaccharide around, suggesting that there's bacteria in a place where it's not supposed. Oh my goodness, why are you doing this to me? Ah, in places where it's not supposed to be. And, if we go back to our example of the Middle Ages, right, you've got bad abdominal pain, right lower quadrant, and it's sharp and stabbing. What do you have? Well, it's very clear what you got. You've got appendicitis, right? And what was the likelihood of you surviving appendicitis in the Middle Ages? I mean, this is before modern surgery. This is before any antibiotics. I mean, you probably would get some bloodlet, and that's about all they could do, which does not help appendicitis. And the reality is that its mortality rate, a lot of people will just spit out an answer of like 100%, 90%, something like that. But actually, it was about 30% in terms of natural history mortality, which, only 30%. Obviously, that's a frightening statistic this in the modern era. But in fact, if your appendix got inflamed, your body knows a little bit what to do about that thing. Or if you got a UTI, right? If you got a UTI in the Middle Ages, there wasn't any like nitrofurantoin around to take if you started having dysuria. So it was up to your body to fight it off, or if not, then you would die. But in the majority of cases, UTIs do self-resolve after a decent amount of uncomfortableness, and certainly fevers if it starts to ascend. But of course, it gets more and more dangerous as you get higher and higher up. But remember, we live with all of these gram-negative bacteria inside our stomachs, and most of the time in the intestines, and most of the time everything goes fine. But they do sometimes get out of control. They sometimes riot and go into places they're not supposed to be. And it's the body's immune response to these lipopolysaccharides that is so inflammatory that's there to control that. But unfortunately, when we iatrogenically are giving patients, chemotherapy, which is wrecking their immune system, um, and destroying all the white blood cells, now you don't have that normal response, but you still have the inflammatory response. So now you have all of these bacteria circulating in your bloodstream, and you have this massive inflammatory response to that. And it's actually your own body's inflammatory response, that lipopolysaccharide binding protein that's going to trigger toll-like 4 receptors, TLR4s, that's going to lead to the inflammatory cascade. And it's that own cascade that's actually what's killing you, at least in the short term, right? Now, eventually, if you didn't have any of this inflammatory response, then your bacteria would just go hog wild in your body, and you would die that way as well. So, it is obviously a necessary thing, but in certain situations, particularly when the immune system is broken down to the point where bacteria are circulating in the bloodstream, this inflammatory cascade can ultimately be your demise. So that is why gram-negative sepsis is so severe, especially in neutropenic patients. And the reality is well, how many bacteria? So somebody comes in presenting in sepsis. This is why the Surviving Sepsis campaign has that hour of antibiotics. Get the antibiotics in as soon as you possibly can. And why is that? Well, remember, let's say you have, let's say the patient has 1,000 bacteria floating around in their bloodstream. How fast do bacteria divide? Well, E. coli divides quite quickly. In a nice circulating 37-degree bath with plenty of nutrients around, which describes the human body perfectly, every 20 minutes. Which means in an hour, how much worse is the problem? And I know your temptation is to say 3 times worse, but it's actually even worse than that, because remember, it's doubling time. So in 20 minutes, the problem is twice as bad. That's fine. But in 40 minutes, how much worse is the problem? 4 times worse. And in 60 minutes, how much worse is the problem? That's right, it's 8 times worse. Remember, it's 2 to the third, because there's 3 doubling times in that hour. So really, in 1 hour, you now have 8 times as many bacteria and 8 times the problem that you had before that hour. So it is super important to really get that time down as fast as you possibly can. All right. And so why is that important? So why use aminoglycosides? Well, remember, we are living in an era of antimicrobial resistance. So somebody is coming in with severe sepsis, and it's most likely caused by gram-negatives, and gram-negatives of all the bacteria are the most likely to have difficulty with susceptibility and huge amounts of antimicrobial resistance. That's when maybe using a combination, because let's say you have a drug-resistant Pseudomonas that's carbapenem resistant, but happens to be amikacin susceptible or tobramycin susceptible. It's much better, even though the beta-lactam is the better antibiotic, it's much better to have an antibiotic than no antibiotic. And that goes back to our first principle, right? It is better to select. Don't try to select for patient resistance to microbes, because especially in that situation, the patient is going to lose 100% of the time. So much better to have an antibiotic on board. And that's why with severe sepsis, particularly in immunocompromised hosts, it might be reasonable to add a second antibiotic, combination antibiotic like aminoglycosides can save lives. And we've certainly seen that in clinical practice, where bacteria comes back and is resistant to the beta-lactam, but happens to be susceptible to the aminoglycosides. So keep that in mind, particularly for those immunocompromised patients. The other place where we can actually use it is, remember, one of the toxicities was nephrotoxicity. And why is it nephrotoxic? Because the aminoglycosides concentrate in the kidney, which means they actually will be excreted for up to 3 days in the urine, at least in adult patients. I don't think we have as much good data, but 3 days in the urine. So if somebody is stuck being admitted to the hospital, then a short course of aminoglycosides might actually be a reasonable thing to do. You're not going to necessarily, with a short course, see the biggest problems of ototoxicity and nephrotoxicity, but you are getting all the benefits of it, which is, concentration in the kidney where the infection is, and prolonged excretion into the urine. There's even some new studies looking at just a single dose of aminoglycoside, a single dose, and we'll talk about dosing sort of separately, and a little bit of pharmacokinetics and time over MIC and that kind of stuff towards the end. Otherwise, I think it's a little bit too much at once. But sometimes a single big dose of an aminoglycoside can in fact cure a UTI, especially if it's a simple cystitis, as opposed to, of course, pyelo. So that's another good use, and we do use it a lot in pediatrics. And not just in pediatrics, but really in infants. And why is that? Well, if we look at the common causes of infant fevers, especially in an otherwise well-appearing infant, and we'll talk about the distinction between the otherwise well-appearing infant and the sick infant. But in an otherwise well-appearing full-term infant, the most common cause of true bacterial infection, well, in a lot of cases, in fact, in most cases, in a well-appearing infant with a fever, it's probably a virus. But studies of back in the day did show that 5 to 10% can have a life-threatening bacterial infection that's just getting going. And of course, the biggest offender in that age group is GBS. But particularly, especially nowadays, with so many more preterm births and infants surviving longer in NICUs, the preterm infants are at higher risk. In fact, E. coli and the other enteric gram-negatives and gram-negatives now become the most likely cause. So in full-term infants, it's still GBS, although thanks to early onset sepsis campaigns and GBS prevention campaigns, we certainly knocked that number down. But it's still probably the leading cause, even in otherwise healthy infants, of serious bacterial illness. But E. coli and gram-negatives close second, and definitely a first in NICUs. And preterm infants. And then, we always mention listeria. It is very rare. You probably go through a career and see, especially in pediatrics, maybe see one if you're doing general. I can say I've seen maybe like 4 or 5, being an infectious disease specialist, but it is very rare. And that's not to say that it can't be deadly, but it's certainly not nearly as common as GBS and E. coli. So why do we use AMP and GENT? Well, AMP and GENT is a decent starter combination for listeria. It's a good combination for GBS. But where it really struggles, and you're probably thinking this now because we talked about head-to-head gram-negative infections, what is a good antibiotic for the gram-negatives? And I have news for you, it's not GENT, and for 2 reasons. So the first is, while it does have a reasonable spectrum of activity, it's not perfect. And not only that, what does E. coli love to cause in infants? Meningitis. And what do the aminoglycosides not do very well is cross the blood-brain barrier. So, yikes! It's not the most effective empiric antibiotic for gram-negative meningitis, that's for sure. And ampicillin, good old ampicillin does, and we'll get to that, as we talk about the beta-lactams later, does work on E. coli, but it does not, unfortunately, cover very many E. coli. There's only about 40%, 50% of E. colis that are still susceptible, in some cases even less, but not a great starting point if you're dealing with a septic infant with E. coli. So there's always this dual concern between using too many antibiotics and using not enough antibiotics, right? We've talked about that. And if you use broader spectrum antibiotics, for instance, if I was truly worried that an infant was sick and they likely had E. coli and they were, there's a good chance that there's E. coli meningitis, AMP and GENT is not the combination to use. You would generally want to at least have a third generation cephalosporin to cover most of those. And unfortunately, as we start to see more and more ESBLs just out in the community, it is not even clear that a third generation cephalosporin is going to be sufficient in the coming years. But for now, it tends to be. But, you know, but if you overuse it, right, the biggest problem with infants is that sometimes they just get sick and they look a little bit sick and they look a little bit funny, and especially preterm infants, and their breathing rate changes and they start having Brady's for no good reason. And so there's always that concern. Well, that's an early sign of sepsis. So what should we do? Well, we should give antibiotics right away. But what you end up doing is giving a ton of antibiotics to these infants every time they twitch or change or something goes, and you end up giving, if you were using a third generation cephalosporin, you end up giving a ton of that to these infants who might not even have infections because you're worried and you don't want to miss the boat. So in that situation where an infant's just kind of acting up, it's not necessarily terrible for Ampigen to be used, because then you're not selecting this inordinate amount of resistance. And that's the duality. That is the conundrum. And there is no great answer. You want to make sure, especially if an infant is truly sick, that you're giving them the appropriately broad spectrum antibiotic, right? If we go back to our principles, where are my principles? Don't, number 3 is super important, but number 4 is there too, because if you overuse antibiotics at some point in the future, none of them are going to be available to you to use. And that is where it's still not unreasonable for Ampigen to be used for otherwise well-appearing infants who need to be on antibiotics, or NICU babies who are just having some concerning signs, but not enough to be warrant full-blown jump on them with everything. But that being said, it is not that great a combination for a truly septic infant, or a truly where you don't necessarily know that it's GBS or a gram negative. All right, so just to confuse you, there you have it. There's no right answer. All right, so that was a lengthy talk of aminoglycosides, but let's keep moving along. Sorry, get bigger. I want the thing where it gets bigger too. All right, and then we have to erase all these guys. I think that's good. We cleared the ship. All right. So let us talk about doxycycline. So we have let's pick a different color. Let's pick this ugly color. Doxycycline. So we have tetracycline. It's still around for one use case, and we'll talk about that. But really, the predominant antibiotic you're going to be using on a day-to-day basis is doxycycline. Doxycycline, let's talk about its spectrum of activity. Let's go a little faster with this one. So, does it work on MSSA and MRSA? It does. In fact, it's a great back pocket drug for MRSA, at least for now. There are probably increasing rates of doxycycline resistance in MRSA, but for now, most MRSA remains susceptible. It is unfortunately not. So, usually you can generalize things and say, well, if it kills MRSA, it should kill wimpy old group A strep. This is one situation where group A strep has got the memo, but staff did not. And so it is not a good use case for group A strep. There's just too much resistance. Now, are some susceptible? Absolutely. There certainly are. Probably about 60-70% of strep strains are susceptible, but different with different communities. At least in mine, it's about 60 to 70%. But there is resistance, and unless you have to be careful. So good for MSSA infections, like a nice honkin' skin abscess, not necessarily great for cellulitis, I don't know, and definitely a concern if it's something like erysipelas or something more classically group A strep, because you might not get lucky. It does actually have reasonably decent pneumococcal coverage. So, so again, somewhere in the neighborhood of anywhere between 70 and 90%, depending on community to community. But it is there, and it does in fact work on pneumococcus. But again, not perfect, not perfect. So it's sort of like check question mark. Enterococci does not really work on the enterococci, so dead in the water there. Um, Tetracyclines, way back in the day, used to be great for the gram negatives, but unfortunately, there's just so much resistance that unless you knew that it was tetracycline susceptible, that you wouldn't use it. Doxycycline, also not the best in terms of urine excretion. Can it work? Yes, there's enough excreted that it might work, but it's generally just not that useful for your gram negatives. Um, Pseudomonas, absolutely no activity, zero, and so not a good choice for your environmental gram negatives. Curiously, though, it does have activity on gonococcus, and so not perfect, but there are studies where people are using PrEP, uh, pre-exposure prophylaxis, doxy prep. So of course there's the antiretrovirals using for HIV prep, but there's actually using doxycycline for prep. You can prevent transmission of syphilis. You can prevent transmission of chlamydia, and you can prevent transmission of gonococcus. At least for now, until things get the bacteria become resistant. But PrEP for now does actually seem to prevent those infections. There's always, of course, the debate of using PrEP. Does that encourage the development of resistance? There is some argument to that. But there's also the argument of, well, you're reducing the total number of infections and therefore the total number of exposures that those bacteria have. So it's not there's not a completely perfect solution to this problem. Um, and does it work for the atypicals? And yes, this is exactly where doxycycline shines. You have, you go on a safari and you end up with a high fever in the middle of the wilderness in Colorado or, in Mozambique or any of these places, and you have some sort of weird, terrible rash. This is where doxycycline shines, right? It treats all kinds of unusual infections, Lyme disease, rickettsial infections. Uh, in the cousins of rickettsia, you have like Ehrlichia and Anaplasma, and all of those are sort of cousins of rickettsia. So it treats all of those. So doxycycline is really this is where it shines. Now, we are using it probably more and more for drug-resistant mycoplasma, which means more mycoplasma exposure to doxycycline, which means we probably only have a decade left where doxycycline is a good alternative for mycoplasma. But at least for now, it does really shine. So all of these guys, doxycycline is the treatment of choice. Not great anaerobic, not great certainly not great gram-negative anaerobes, and not really any TB. There's a couple NTMs, but pretty much no. So that's doxycycline. So when do we use it? Well, you can use it in a cellulitis. One anaerobe I didn't talk about um, C. acnes now. So it used to be P. acnes, now it's C. acnes. So doxycycline does work on C. acnes. So you will see teenagers being put on this for acne. Although again, remember, antibiotics should be second line therapy. Retin-A should be your first line agent, because eventually you will select resistance of the acne. So you'll use it for acne, cellulitis, and then of course any interesting jungle associated or forest associated infection. Good. Let's see. So let's talk about toxicities. And actually, yellow is a good choice for this because one of the most important ones, and really the most important one, you tell your patients, is the good old sun. Skills are really dying these days. Uh, Doxycycline gets into the skin and causes very severe burns. What happens is it's in the skin, and it reacts with the UV light to form a intermediate compound that's toxic, and so it just enhances any sunburn to a huge degree. And that is, I think, where people really will get into trouble with doxycycline is teenagers who don't listen to you, won't remember a thing you said, and but they do know that they don't want acne, so they're going to take their doxycycline. They're going to do it reliably, but they're going to go out in the sun without sunscreen, and when they're not thinking about it, go to the beach with their friends or something and just get horribly, horribly burned. And so you really have to advise them, drill it into their heads. Look, if you're on this medication, you need to be careful about sun exposure. Some places, like if you're in jolly old England, it probably doesn't matter because you've never seen a day of sun. But in Southern California here, it is certainly dangerous. Here, Arizona, Texas, any of those places where there's a lot of sun, you have to be especially careful. So that's the most important thing. That's the number one thing you gotta warn patients. Number one. And then number two comes up in pediatrics is the classic tooth staining. And actually stain any calcium-rich source, so like bones and such can also be stained. But what happens is little kids have their baby teeth, right? And the adult teeth are slowly developing, and while they're developing, they're taking in a lot of calcium and forming, and so the tetracycline especially likes to bind to calcium and can get into the calcium that's going into the teeth, and then you end up with sort of brown, discolored teeth. Now, that being said, tetracycline was definitely more of the issue than doxycycline is. So I always ask people this question. All right, you've got that 6-year-old. So we're back to 6-year-old in Appalachia going out hunting, and comes back and now has that high fever and spotty rash. What do they have? They have Rocky Mountain spotted fever, until proven otherwise anyways, a potentially deadly illness with a fairly high mortality rate when untreated. So what do they have there? Rickettsia. What's the treatment of choice? Well, the treatment of choice is, we said it earlier, was doxycycline, but he's 6 years old, and that tooth development is still happening. And if you gave that doxycycline, could you stain their teeth? And so what else should you use? And of course, there's usually some mumbling, and some people get the right answer, and some people go, well, maybe we should use something else. I don't know, like penicillin or something. Oh, yikes. The answer is still doxycycline. Because, I know I'm in LA, so brown teeth, death, it's a little bit of a conundrum, but for most places in the world, we should choose life over brown teeth. And so people, obviously had to use doxycycline, and in certain cases, and it turns out that the tooth staining, at least with doxycycline, is largely overblown. Short courses of doxycycline, like used to treat Lyme disease or used to treat rickettsial infections, do not cause that permanent tooth staining. Unfortunately, though, very long courses, like if you were using it for an osteomyelitis, and we've had to do that sometimes where there really is no other option, then that's where you can end up. And even prolonged course of doxycycline, even in especially high dose, even in older people can still cause that tooth staining. So you warn people, look, we got to use this. There's generally not likely to stain the teeth, but we do have to use it. This is a serious infection, and just let people know that was a decision being made. All right. Because again, there's not really a great alternative. The alternatives to rickettsial severe Rocky Mountain spotted fever is chloramphenicol, which is going to be impossible to get. So even if you're hypersensitive to doxycycline, the answer is still desensitize and give doxycycline. Maybe use a bridge, one of the other things that treat atypicals, like you could maybe use levofloxacin as a bridge while you're ramping up the doxy. A third and fun one. Let's take that poor adolescent with acne who's taking doxycycline, and they take it right before bed, and then they wake up in the morning and they have severe chest pain. They decide they're going to get a glass of water. The water burns when they're taking it down, so the chest pain even got worse, and now they're freaking out that they're having a heart attack. That is pill esophagitis. It is not a heart attack. Pill esophagitis. So pill esophagitis is one of the other problems. And if you um, ever used doxycycline and had to give it through a PIV, the patient will complain. It feels like it's burning because it is a very reactive molecule. And so imagine a big pill of that stuck, and they are reasonably big, big pill of that stuck in your distal esophagus overnight because you didn't sit up for about 10, 15 minutes after you took it and drink some water and maybe eat a cracker. Um, to wash it down and then brush your teeth. So it's stuck there in your esophagus, causing a lot of inflammation and pain. So pill esophagitis is a known problem, and so warn your patients: hey, don't take it right before bed. Don't just like take it and then head to bed. Make sure it passes, or you will have a very, very bad few days. And then, is there any other thing? Let's see, pill esophagitis. Oh, and then of course you do have to warn about calcium. Now again, doxycycline not likely to have an issue, but we do tend to have people avoid dairy an hour before, an hour after. The official package recommendation is like 2 hours before and 1 hour after, or vice versa. But about an hour before and after is usually sufficient since it doesn't bind nearly as avidly as tetracycline does. So we do tend to avoid calcium-rich foods, spinach, those kinds of things, as well as dairy, around the time of taking doxy. Which gets us to tetracycline. Well, tetracycline definitely has the two-staining issue, so I would generally avoid it in any case. But when do we use it? Why use tetracycline when we've got doxycycline? Well, the answer is it's still, interestingly, part of the backbone of treatment of H. pylori. Helicobacter pylori, so you will still see tetracycline used. Doxycycline is, for whatever reason, just not as effective on H. pylori as tetracycline is. So part of the combination regimen, never alone, but in combination of treatment for H. pylori, tetracycline is still used. Okay, so that is doxycycline. Moving right along. Let's move to... let's pick something else. Getting bored of these colors. Should we do the magenta? Do magenta for clindamycin. So, what does Clinda work on? So Clinda used to be excellent antibiotic to use for certain infections, and we'll talk about that. So does Clinda work on MSSA? Yes, it does. Does it work on MRSA? Yes, it does. With an asterisk here. Does it work on group A strep? Yes, it does. Group A strep, great. Works on group A strep. Fantastic. Does it work on pneumococcus? Yes, it does work on pneumococcus. Does it work on fecalis? Not so great. Faecium, not so great. So probably not very good for these guys. Does it work on any of the gram-negatives? Clindamycin has no gram-negative activity. No gram-negatives. So it doesn't work on any of your anaerobacteriales, doesn't work on any of your environmental gram-negatives, doesn't work on any of your mucosal gram-negatives. Not ideal. Does it work on atypicals? Not really atypicals. So that is out. And how about anaerobes? Does it work on anaerobes? The answer is yes to anaerobes, but not the anaerobes you were hoping for. So back in the day, interestingly, even though it's technically a gram-negative anaerobe, it did have activity on B-Frag. But now, with resistance being what it is, there is almost no B-Frag left, that is. But it does have still some activity on the gram-positive anaerobic cocci and the gram-positives like certain clostridiums, but not one in particular. You probably already know the answer. All right, so when can we use clindamycin? And then we'll talk about its toxicities. So, you know, it seems like a great antibiotic for cellulitis, right? It's so far we've talked about trimethoprim sulfa kind of having that concern with group A strep. We've talked about doxycycline kind of having that concern with group A strep. Certainly, something like Keflex will have a problem with MRSA. So you're like, oh, is there one antibiotic, like a one-stop shop for cellulitis? And it used to be Clinda. Clinda was that one-stop shop. It would treat MSSA, it would treat MRSA, and it would treat group A strep. The trifecta of cellulitis, right? Most cellulitis caused by those three organisms. But unfortunately, as time has gone by, MSSA has gotten better about being resistant to Clinda. So probably like, 10 to 20%, sometimes as high as 30. And MRSA, depending on community to community, can have a huge range from 30 to, 70% resistance to clindamycin. So all of a sudden we're back to, well, that's not great odds, right? That's a little bit better than levofloxacin odds, but not great. Um, and even group A strep has between 5% and 10% resistance. So not perfect for group A strep either. So pneumococcus, again, you're probably around anywhere from susceptibility percents. Oh, so I'm Yeah. So in terms of susceptibility percents, meaning how likely are you to succeed, but anywhere from 60 to 80%. Sorry, I should say group A strep susceptibility percent is anywhere between 90 and 95%. So pretty good, but not perfect. And so if you have a severe group A strep infection, clindamycin, you got to worry about that 10%. But pneumococcus 60, 80%. Again, could you get away with it? In many cases, yeah. For treating a pneumonia, could you, especially if it's most likely a pneumococcal pneumonia, could you succeed? Yeah, the majority of the time you'll succeed, but there's a huge minority that you won't. And of course, when you're dealing, the more severe an infection is, the more you have to be right up front. So, with cellulitis, it's the easy thing about cellulitis is it's right there, it's visible. So, and the patient can feel. So if it's, you got a lump and you want to start Clinda, there's nothing necessarily wrong with that. Just have to advise them like, hey, there is resistance to this antibiotic. So if it seems like it's getting worse and worse, and you're noticing it getting worse and worse, and you can even draw a little line around it for them, then we got to switch you, and really should start to shrink within 24 to 48 hours. And if it's not doing that, then we've got a problem. But of course, remember the best thing to do for an abscess is to drain it. That's right. That was the right answer. Warm packs and drainage is the right answer for most simple skin abscesses. You don't even need antibiotics. All right. What are the big side effects with Clinda? So the big side effects are, probably already guessed it, the black box warning. I should have done it in black, but I'm too lazy. C. diff. So of all the antibiotics, right, loves to kill anaerobes, but not the right one, but loves to disrupt the gut flora. And anytime you disrupt the gut flora, you are increasing the risk of C. diff infection, and particularly clindamycin. So C. diff is probably the number one. Otherwise, it's a fairly well-tolerated antibiotic, and there's really, hypersensitivity rarely does happen, but it's rare. You can have some mild hepatotoxicity, but in general, it's quite a safe antibiotic, um, minus the C. diff risk. All right. Interestingly, clindamycin does have one other use, and so you might see, you're like, what is this about? Uh, so clindamycin has some activity on malaria. Malaria. What? And it also has some activity on things like babesia. Babesia? What's that about? So curiously, these group, so malaria, babesia, cryptosporidium, they all fall into this group called the apicomplexa. Toxoplasmosis is also here. And the apicomplexa used to be very friendly photosynthetic organisms. So they're sort of single-celled organisms, and they had their little chloroplasts in here, right? Nice green chloroplasts, and they would absorb the sun. Oh, I got rid of my sun, but just imagine that beautiful sun I drew shining on this chloroplast and making energy for the world. And then it decided it wasn't going to have any more of this. It was going to be a taker, not a giver. So it sort of mutated its chloroplast. Let's make it red for evil. It mutated its chloroplast to becoming a parasitoplast. And this whole family, Malaria, Babesia, Toxoplasmosis, are actually all in that family. And interestingly, just remember that these single-celled eukaryotic organisms are quite highly related. I mean, even though now that we're humans, we're significantly more divergent from them, but we do still have homology with all the way down to our single-celled eukaryotic roots. And these guys are even more closely related to the bacterial things. So their ribosomes do in fact get inhibited. Their 50S ribosome does in fact get, or their ribosome does in fact get inhibited by clindamycin. And so that's why you might even see clindamycin being sometimes used in these sort of wild infections that you wouldn't necessarily think of being clinda susceptible. So there is that one little fun caveat where you might see clinda used. And actually, doxycycline can have some activity on malaria and some of these other ones as well for that exact same reason. They're just, it's homologous enough that it provides some benefit. All right. Oh, and then last thing is let's talk about the resistance of Staph aureus, because there is a fun little clinically relevant factoid. So, I normally ask you what is the way we look at staph resistance. And of course, staph resistance, you can just have a gene that's mutated that the 50S ribosome no longer binds to clindamycin, but still functions perfectly fine. And so that's what we call constitutively resistant. Constitutively resistant, meaning it's just always there, it's always on, it's always resistant. But we also have a new fun way of dealing with this, and this is going to come up later when we talk about the M-space organisms and beta-lactams, but inducible, oh my God, pretty sure I spelled that right, inducible, and internet, hello. So inducible resistance, fantastic, got it right on the first try. Inducible resistance. Um, and what happens here is let's take a plate. Let's take a petri dish. Scientists love petri dishes. That's going to be just have to be good enough. And let's put down a disc of erythromycin. Now, erythromycin is a macrolide antibiotic, which we haven't talked about yet, but we're going to get there. But Staph aureus is almost never susceptible. Only about 1-2%. You do see it from time to time. We've even seen a MRSA strain be susceptible to erythromycin once in a while. But by far and large, it is Staph aureus is resistant to it. So what you have is the erythromycin disc is going to diffuse out into the agar, right? And its highest concentration is going to be nearest to the disc, and the lowest concentration is going to be farther away. Right? Do, 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 boo, 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 boo. And let's say you plate a lawn of bacteria on this plate, and then you wait for them to grow, right? So the plate is initially clear. You've got the erythromycin disc, but the bacteria are going to start to grow. And you're going to look for the zone of inhibition. And if you look at it to start with, there might be a tiny little clear ring around the disc because the concentration of erythromycin is so high that even though it's constitutively resistant, it's able to overcome that resistance. But everywhere else, the Staph aureus is growing. So it's like completely opacifying the plate, right? Fantastic. So erythromycin did nothing. Let us now plate. Imagine a plate. Let's give ourselves some room. Oh, you know what? I think I have a circle tool. Don't I have a circle tool? I could have made a circle. Much easier than what I was doing. Okay, so here's our plate. Fantastic. Look at that. So much better than mine. All right, and now on this plate, let us put a clindamycin disc. Let's put C for clindamycin. Okay, we put a little disc of clindamycin down here. And let's grow it. Let's grow the bacteria. Let's plate this whole thing with Staph aureus. And the Staph aureus is inhibited. It's like, oh my gosh, there's a whole zone around it. I should have used the circle tool again, but there's a whole zone around the clinda disc where the clinda concentration is even at not necessarily very, very high concentrations, the Staph aureus can't grow. So what's the problem? Sounds perfect, right? It's clindamycin susceptible. Clinda susceptible. Huzzah, you won. Except that if you leave that plate out there, you'll start to notice in about, 20 to 30% of cases, depending on strain to strain, you'll notice that it starts to creep back in fairly quickly. And now all of a sudden, it's not looking so susceptible. And in fact, oh my gosh, it looks just as bad as that erythromycin disc looked like. What is happening here? This is inducible resistance. What happens is the Staph aureus does have a gene that is ready to become resistant to clindamycin, but it's not being expressed. So it's sort of just hiding there. It's normally using its regular old gene that's clindamycin can inhibit, but it's got a backup just in case that's resistant. And if it starts to see the clindamycin, it will start to grow back. And this is a big problem because you initially looked at the lab report and said it was susceptible, and hey, I've got a Staph aureus infection and it's susceptible. And now it's starting to get worse. The other big problem is you might not have a culture, right? You have a abscess, nobody wants to drain it, you don't get cultures, you don't find out that there's this inducible resistance. Um, and as such, the patient seems like they're getting better, right? Because initially it does work, right? It inhibits the growth. But so their osteo is getting better. They're feeling better. Their whatever is starting to do better, whatever infection they have. And then all of a sudden, 3 days go by and things start getting worse again. What's happening? Well, it means two things happen. One, your patient, unfortunately, his immune system was not able to pick up the slack and fight the infection off. Because a lot of times, simple skin infection, if you've turned the corner, you're doing your warm packs, you've lanced it, and somebody gave you Clinda just for funsies, even if there's inducible resistance, it might just get better. So you might have clinical success. But if you got a deep-seated infection that is not adequately drained, not adequate source control, or just severe enough that the immune system alone is not going to cut it, then that's where you start to see clinical failure with clindamycin. And you have to be aware of this inducible resistance because you might meet up with it clinically, even if you don't necessarily know at it from the lab. The way the lab actually does it is kind of fun, so we'll just talk about that super fast. You can skip ahead if you're not interested, but it's called the D-test. So we talked about the erythromycin, and we talked about clindamycin discs. Okay, go away. I just need a pen. So what you do is you actually plate a erythromycin disc here on the left side of the plate and a clindamycin disc on the right side of the plate. And recall, and then you're going to plate a lawn of bacteria. But remember that even though the erythromycin is only that tiny zone of susceptibility, and then you're going to have growth everywhere, the erythromycin is diffusing out. And it's meeting up to some of those bacteria that are also seeing clindamycin. So the clindamycin is doing the same thing, right? And what's going to happen is you imagine that the circle of clindamycin should be like this, right? It should be a nice round circle around it. Again, why am I not using the circle tool? I know it's better than my freehanding. But here we go. We should have a nice round circle. But what happens is the erythromycin is a potent inducer of the gene, whereas the clindamycin is a little bit less potent of an inducer of this resistance gene. So rather than having to wait for days and days for the staph to start to express it and start to grow out, you can do it right away by doing this test where this is a potent inducer. So these bacteria that live in this zone right here where they're seeing reasonable concentrations of erythromycin still, they are able to grow. So this area is able to fill in. So whereas this would generally be an entire lawn, right? The whole thing should be shaded in. You need a fill tool. But while this whole thing should be filled in, there was supposed to be a nice circle around that clinda, but there's not. It's blunted because the erythromycin helped induce that resistance. And so what does this look like to you? Well, there's this one line and then a nice kind of circle shape going to that line, so it looks like a D. It looks like a D, and this is called the D test for that reason. So that's looking for the inducible clindamycin resistance gene. And many labs will provide that for you and let you know that, in fact, there is inducible resistance. So be careful, or they might just report it as R resistant, even though there's inducible resistance. So that is where you can run into some interesting phenomena with clindamycin of like getting better, getting worse again, or just getting better, and even though there's inducible resistance, still getting better, because it really depends on that other half of infections that we don't like to that we don't think about enough, which is the immune system side that's also helping out with the infection. All right, so that was a lot. Let us still. Oh, you aren't erasing. This is like a permanent circle. Am I stuck with this? What is happening? All right, so well, here's the downside, I guess. Eraser, where are you? Oops. Yeah, from my group A strep. I can make it small. Can I zoom in so I don't? You and you. All right. So, my goodness, where are we? The macrolides. So, we have erythromycin, chloramphenicol, and azithro. And we'll talk predominantly about azithromycin and just mention the other two in a little bit. But let's start with azithromycin. What does it work on? Does it work on MSSA? Very poor activity. MRSA, like we said in the clindamycin part, very poor activity. Maybe only a few percentage. So once in a while, could be. I wouldn't even trust it in that situation. I would worry more that it was a lab error than it was actually a true finding. But it is a consideration once in a while if you really had absolutely no other options and it happened to be susceptible and you knew it. Group A strep, though. Let's talk about the streps individually. Group A strep, strep viridans, and strep pneumo. So kind of going from not necessarily the least severe, because group A strep certainly can be deadly, but in terms of its evolutionary intelligence, it is low. Azithro, about 90 to 95% susceptibility. So there is a small portion of group A strep that is clinically relevant that will be resistant. So when you have a patient with penicillin and amoxicillin allergies and you want to use an alternative agent, azithromycin is not necessarily bad, but just remember that there is this group of patients who will not be treated properly with azithromycin. Strep viridans tends to be a much smarter group of evolutionarily intelligent group of bacteria. So only about anywhere between, really depends strain to strain. So it's really hard to put this into numbers, but anywhere between 60 and 70%, or but sometimes even as low as like 40. So a huge broad range of susceptibility depending on virulence strain to strain. But it is definitely more resistant. And similarly, strep pneumo, depending on community to community, will have very different azithromycin susceptibility rates. So, again, between, somewhere around 40 to 50 to 80% can be susceptible. So very broad range, very hard to predict, totally dependent on the community you're in and times how they are. So you have to be. So is it great for any of these? Well, it's not great for certainly the smarter of the strep species. Probably still reasonable with that kind of success rate for group A strep, as long as it's not a severe infection with group A strep. Anaerococci, dead in the water. So kind of think of them as super strep pneumos. Strep pneumos, even smarter evolutionary cousin, and you are really batting low average at that point. In terms of the gram negatives, azithromycin, particularly for the enterogram negatives, is generally pretty poor, with the exception of E. coli, certain E. coli strains, ETEC, which stands for enterotoxigenic E. coli. So traveler's diarrhea, that kind of thing, azithromycin is still quite reasonable in terms of its efficacy on ETEC. But for a garden variety urinary tract infection with normal E. coli strains that are in most people, the answer is unfortunately no. It does have quite a decent amount of efficacy on many non-typhoidal salmonella strains. Can rarely, or can on occasion, have efficacy on typhoidal as well, but you just have to be very careful. Always make sure you're getting susceptibilities, because typhoidal is becoming more and more resistant to things. Shigella is another good use of it. Remember always to be careful of EHEC, because hemorrhagic E. coli, you always worry about antibiotic use. There's varying studies showing risk in terms of whether it's really true or just an association between antibiotic use and EHEC-related complications. And hemolytic uremic syndrome. And let's see, what else? Where are we? So we talked about these guys. No activity on Pseudomonas, not really any activity on these guys. Did historically have activity on gonorrhea, and in fact, one of the reasons that we used combination in the past, so we used to use ceftriaxone plus azithro, and a lot of people thought the azithro was just for chlamydia, but you still recommend the use of combination ceftriaxone and azithromycin for pure gonococcal infections. And the reason was it was an attempt to reduce the risk of resistance developing. Hopefully, again, going back to that idea that in vitro when we use combinations of antibiotics, we tend to reduce the resistance, but unfortunately, gonococcus is now sufficiently resistant to azithromycin that we no longer recommend it, and instead we just up the dose of ceftriaxone to overcome the developing resistance of Neisseria gonorrhea to third generation cephalosporins, which means we are rapidly running out of reasonable outpatient managements of that, and hopefully we'll not have to, in the near future, start to move to things like carbapenems, like ertapenem for treatment of gonococcus. But there's a reasonable chance that will happen in our lifetimes. Haemophilus does work on that. Moraxella, certainly gold standard for bordetella pertussis infections. So it definitely has some decent activity on the mucosal gram negatives. And then in terms of atypicals, it does have activity on Mycoplasma, Chlamydophila, again, Mycoplasma resistance rates, which I think we mentioned which I think we mentioned in another lecture, are unfortunately increasing, and particularly in East Asian countries and South Asian countries where azithromycin use is wildly overused. The mycoplasma resistance rates are now as high as 90+%. So you are not going to be very successful if that's where you picked up your mycoplasma. In the US, it's still about 85 to 90% susceptible, but you will have outbreaks. Like I'm fairly certain the outbreak we more recently had in the LA area was a zithro resistant strain because when we switched antibiotics, people would rapidly get better. Again, now whether you have to treat it or not, that's the other debate. But it does have frequent resistance, especially in certain countries. Chlamydia is still typically susceptible, so it is still a reasonable treatment, although we've generally moved to doxycycline for the treatment of non-gonococcal infection, of genital infections. Legionella will work. Rickettsia, it's a little bit more resistant, a little bit less likely. Can it work? It might have activity, but doxycycline is really the answer for those concerning things. Anaerobes doesn't have much activity on anaerobes, and doesn't really have much activity on tuberculosis, or doesn't have any activity on tuberculosis. But remember, it is the backbone of treatment for Mycobacterium avium, so it certainly does have its occasional uses in non-tuberculous mycobacterial infections. All right, so when can we use it? Well, you can use it for a strep throat, but just be careful. You can use it for acute otitis media, right? It does have some pneumococcal coverage. It does have some Haemophilus and Moraxella, so you will get, sinusite. It is sort of second line if somebody really can't tolerate anything else and you're dealing with thousands of allergies. Then you can consider its use for sinusitis, but just realize it's not going to be nearly as effective as in terms of overall efficacy as amoxiclav. Certainly is first line for bordetella pertussis, and certainly can be used in community-acquired pneumonia. Particularly, while it does have some pneumococcal coverage, just be careful of a focal bacterial pneumonia. Probably wouldn't be my first choice by a mile, but would be reasonable for an atypical pneumonia coverage. All right. In terms of side effects, it's generally well tolerated. The biggest issue, or the biggest scariest issue, is the QT situation. So you can prolong the QT interval, and if you prolong the QT interval, you do raise the risk of sudden cardiac death. So there is that big warning about the QT interval. But most side effects are just going to be GI related. So it does increase gut motility. That is, in fact, one of the reasons that we worry about, or that we use erythromycin, is to increase the GI motility for patients whose gut motility is impaired. But could there be better uses of antibiotics? The answer was probably yes, but for some people, that's just what works for them. So increases GI motility, so a lot of nausea and vomiting, diarrhea. Those are the biggest concerns with it. But otherwise, generally well tolerated antibiotic. The other thing that we have to warn people about in pediatrics is an association with pyloric stenosis. Now, whether it's truly a cause, or remember, what is its big side effects? Is GI motility. So if you have an infant who is developing pyloric stenosis, and then you suddenly, where the sphincter of the pylorus is starting to get narrower and narrower, and then you suddenly increase the motility of the gut, do you then just precipitate the vomiting that they're going to have anyway much faster by giving them erythromycin or azithromycin? And the answer is it's probably more likely to be that, but because of this association, we do have to warn patients or parents of infants that there is this potential complication. Although again, I think it's more likely that it's just identifying it rather than causing the pylorus to thicken itself, and that's probably just something that was going to happen anyway. That being said, if you have an infant who has who was exposed to like a 6-week-old who was exposed to pertussis and is starting to develop symptoms, azithromycin is still the treatment of choice, even despite this pyloric stenosis concern. So don't avoid it just for that reason. But if there's alternatives for an infant than azithromycin, then you might want to consider using that until they're older. All right. So I think that is everything that we can talk about with macrolides. Yeah. Oh, and I'm sorry, and of course, traveler's diarrhea would be the other reason to prescribe someone that, or prevention of traveler's diarrhea, so they don't ruin their entire trip sitting on the toilet the entire time after spending tens of thousands of dollars on hotels and everything. Not a very fun trip. All right. So where does that leave us with? Okay, the streptogrammins. Let's actually talk about more clinically relevant, then we'll just sort of briefly mention these guys. So linazolid, good old linazolid. So generally, I have avoided allowing people to say works on gram positives but not gram negatives, that kind of thing, because in general, those generalizations, as you've seen with all of these other talks, right, don't work. You can't just say doxycycline works for gram positives because hey, it works on staph, but it doesn't work on strep, and you can't say that for trimethoprim sulfa because you do have to worry a little bit about some of them, right? It's if you just think, oh well, trimethoprim sulfa works on gram positives. Well, it doesn't work on E. faecalis at all, so that's not a great solution. Linazolid, I'm going to let you get away with it. Linazolid works great on gram positives. At least the gram positives here. Works on MSSA, works on MRSA, very low resistance rates at the moment. In 2025, September, what was it now? September 24th, I think, from yesterday. Should be September 24th. Uh, Linazolid is still an excellent option for MSSA, MRSA. Works on group A strep, works on group B strep, works on strep viridans, works on drug-resistant pneumococcus, works on E. faecalis, works on E. faecium, right? It's the treatment of choice for VRE, so vancomycin-resistant enterococci, which tends to be E. faecium. What's your option? Linazolid is a great option. So it works on gram positive. It'll work on some of those other ones like Listeria and Bacillus and all those guys. And it does not work on gram negatives. So no gram negatives. So it works on gram positives, does not work on gram negatives. It does not really work on most of the atypicals. Will work on the gram positive anaerobes. So it does in fact even have activity on C. diff, C. perfringens, tetanus botulism, but not on the gram negatives. And intriguingly, it does work on TB. So linazolid is part of the backbone for extensively drug-resistant tuberculosis, since it's generally well tolerated, and will work on some, but not all of the NTMs. So that is one other additional use case of linazolid, is for these infections. So really, you got a gram-positive infection, you can use linazolid. You got a gram-negative infection, you cannot use linazolid. And once in a while, because mycobacteria actually, for the most part, they're part of the bigger class of bacteria called actinomycetes. So that's all those interesting bacteria that the sulfur granules and nocardia and actinomyces and TB. They're all part of this sort of weird group of bacteria, and mycobacteria have that mycolic acid shell around them that protects them from a lot of these antibiotics, but they're actually technically gram positives, and since linazolid works on gram positives, small molecule lexagenin does work quite effectively on tuberculosis, at least again for now. What are the side effects? So this is a super interesting one. All right, what are the side effects of linazolid? So there's a black box warning on it. So let's choose my black pen. Black box warning for linazolid, and that is thrombocytopenia. Now it can actually suppress the marrow, and it's usually after 7 to 14 days is when you're going to start to see the suppression begin. So short course linazolid, you're not going to see any problems, but as you get longer and longer, the bone marrow suppression becomes more and more intense. And as you suppress the bone marrow, you suppress platelet development, and so there is therefore a bleeding risk that is associated with it, and hence the black box warning for linazolid. But again, short course is not likely to cause that. The other really interesting thing about linazolid, so going back to evolution, so how did eukaryotes, how did humans come to be? So recall we have these bacteria called archaea, right? And they're those sort of weird bacteria, are the archaea. And what we think is an archaea at some point ate a eubacteria, like an E. coli, for more likely like a Pseudomonas or something that was, had its sort of early predecessor of Pseudomonas that had a respiratory chain, right? And that respiratory chain, which was allowing the production of utilization of oxygen, got inside this bigger bacteria that did not have it. And rather than eating it and digesting this bacteria sort of lived inside it. And they sort of traded off things. So now this bacteria is living in a reasonably nutrient-rich environment, right? But what's really amazing about it is that this bacteria can be providing it, the bigger bacteria, with ATP. And it formed a symbiotic relationship. And I think, to our knowledge, this only happened exactly once in the course of bacteria. So exactly once, one bacteria ate another bacteria, and they formed a symbiotic relationship. And from this, all eukaryotic life came. All eukaryotic life. All plants, all people, all fungi, all animals, all came from this one original event that happened. And what's really fascinating about it, right, is this one bacteria that has this respiratory chain. What does this become that's producing ATP? What does that become? That becomes the mitochondria. So if you sort of zoom in on the mitochondria, right? Probably shouldn't have drawn it green for chloroplasts, but if you do zoom in on the mitochondria, you will see that they, just like bacteria, have a circular chromosome. And they have their own ribosomes. And remember, this is sort of also mitochondria are entirely passed down by the maternal line. So you get all your mitochondria from your mom. And this is why there are these rare examples of mitochondrial disorders where the genes that are disrupted in the mitochondria have it. But remember, they do have their own little ribosomes, and those ribosomes are, in fact, a 30S and a 50S. They're not the classic eukaryotic ribosomes that are bigger. And so these linazolid is able to get into the cell, into the mitochondria, and inhibit these ribosomes. Crazy, huh? So you, as a human or an animal who's taking linazolid, start to, after a period of time, develop mitochondrial dysfunction. And that can lead to a lactic acidosis. Remember, and in fact, that's a common thing with mitochondrial disorders as well, right? You have lactic acidosis as a feature of them because you have mitochondrial dysfunction. What can you do to generate ATP? You have to go into much more fermentation, anaerobic fermentation, which produces the lactic acidosis. What is a consequence of that? Well, you can start to see the bicarb drop. So after generally a reasonably prolonged course of linazolid, you will start to see an acidosis developing, and your bicarb drops, and it's gapped. It's a gapped acidosis. And the other thing that is a serious issue is you can get optic neuritis. In most cases, it's reversible. So if you've got an adult patient who's, in all their capacity and able to take, tell you they can be taking linazolid, let's say for they have a MRSA osteomyelitis and they have to take it for a while, and they start to see vision getting blurry or any of that kind of thing, you have to stop it right away, make sure you're checking their platelets and make sure you're checking their BMP to make sure that they're not developing serious acidosis. But if you see that, you need to stop it and find a different agent or, put them on something else temporarily until that recovers. The danger is in pediatrics with long courses. Short courses, not likely to have a problem. But with a long course in a child who can't tell you that they are starting to develop visual problems, and you just keep them on at longer and longer and longer courses, they can develop permanent vision loss. So you do have to be very, very careful about linazolid in that group. So that's one last little caveat I'll mention. All right. So those are the big ones. And again, it is your responsibility to look through all of the side effects and toxicities, because there's of course going to be tons more, but these are just sort of the big ones to mention. That leaves us with these last two stragglers. So the streptogrammins, Synarcid or quinapristine, dalfapristine, they are generally reserved for drug-resistant gram-positives. So we'll work on MSA, MRSA, group A strep, all these guys. Certainly an alternative agent for VRE. If you've also got linazolid resistance in your VRE, then quinapristine, dalfapristine is there for that. Doesn't work on gram-negatives and would not be generally used for other purposes. Chloramphenicol, not used in the United States because it's big side effects. We'll just talk about that because once in a while it still shows up from time to time in medical trivia. But chloramphenicol, ooh, I know exactly what I can pick. The biggest concern of it was gray. I'm going to spell it like an American. GRAY, gray baby syndrome. So one of the big concerns was that it's rare, it's very rare, but it can cause a severe aplastic anemia. It's not reversible, which means it kills the bone marrow and that's the end of it. And you either need a bone marrow transplant or the patient dies. It was more common in pediatrics than adults, and the reality though is worldwide chloramphenicol is an excellent antibiotic, and if it weren't for this, we would still use it here. But because it's an overall excellent antibiotic, has a broad range of things, can certainly treat even some difficult to treat infections like rickettsial infections. But because of this very rare risk, we just don't have a tolerance for it. But worldwide, antibiotics have certainly saved more lives than they've killed, and chloramphenicol specifically certainly has saved. It's a cheap antibiotic. It's very readily available. It has certainly saved dozens, thousands of more lives than it is killed. So really gets a footnote for that. But you do have to remember that this is the big concerning side effect of it and why we don't use it. All right, but in the new era of antimicrobial resistance, we might have to bring it out of the closet even despite that risk. Because again, if somebody's truly dying of an infection and the only way to save them is with antibiotics, then you use what you got and the risks come second. All right. So we have finally, throw your hands up, take a break, finally finished the ribosomal antibodies, and then we'll be moving on to this group. But mostly just the beta-lactams, and then maybe we'll have some fun other ones as well. afterwards. All right.